Hello, and welcome to our presentation on cardiac arrest and CPR, determining which training increases survival rates. This is a presentation done by Sarah Albright Alfano, Wajdi Bader, and Jennifer Benson for the class of Methods of Research in Public Health. We'll start off the presentation by stating what we already know about sudden cardiac arrest. According to the 2019 heart disease and stroke statistics provided by the American Heart Association, the incidence of in-hospital cardiac arrest is around 209,000 people annually, while the incidence of out-of-hospital cardiac arrest is more than 347,000 people annually. Most of these outside the hospital cardiac arrests occur in private residences, followed by public settings and nursing homes. EMS response time varies across geographical regions of the country, making bystander CPR and AED use crucial for increasing cardiac arrest survival rates. Those who receive bystander CPR and/or AED use before emergency medical personnel arrive on the scene have a greater chance of survival. So what do we already know about bystander CPR and AED use? We know that those with formal CPR training are more likely to initiate CPR when witnessing a cardiac arrest. In order for the AEDs to be effective, they have to be widely available and accessible to the general public. When they are used, AEDs can triple a person's chance of survival from cardiac arrest. To be most effective, CPR training has to be recent and have included hands-on training with mannequins. Now, what do we mean when we talk about dispatcher-assisted training? We are talking about instructions given by the dispatcher to the bystander on how to perform CPR. The use of dispatcher-assisted CPR protocols in general is associated with a greater chance of bystanders performing CPR prior to the arrival of EMS. It does have its limitations, however, in that not all dispatchers are able to easily recognize a cardiac arrest via phone description and can therefore miss the opportunity to instruct a caller on CPR and AED use if needed. Now, as far as what we do not know, in a population where CPR and AED training is not widespread, is there a difference in outcome for victims of cardiac arrest when a bystander performing CPR has had advanced formal training versus those who are given instructions on the spot via dispatch? Our study aims to find the most efficient and successful way for increasing the incidence of bystander CPR and AED use in cases of outside of the hospital cardiac arrests, and therefore increasing survival rates with favorable neurological outcomes. Does advanced formal training, such as certification through the AHA or the American Red Cross, and hands-on training with mannequins offer a greater survival rate for cardiac arrests versus those who perform CPR as instructed via dispatch? We will compare the two groups of people that have performed CPR and used an AED after having received formal training versus those who did it via instructions from dispatch. We will evaluate the outcomes, including return of spontaneous circulation, 1-year mortality rates, and 1-year mortality rates with favorable neurological outcomes. So our target population are the participants, including the American citizens. Our sample size will include those who have witnessed an out-of-hospital cardiac arrest and who are active participants in performing CPR and/or AED use. We will choose our participants via cluster sampling. Given that the adult U.S. population is about 220 million people, and there are 350,000 outside of hospital cardiac arrest annually, we estimate that the required sample size will have to be at least 36 persons. Our study will be a retrospective cohort study. We will interview bystanders who have witnessed an out-of-hospital cardiac arrest and ask questions about their experience with that event. We will ask questions in regards to any training or guidance they may have received either before or during the cardiac arrest. We will compare the data regarding the outcomes of the people who had the cardiac arrest. As for the choice of a retrospective cohort study, it provides an affordable and easily accessible population. We will use cluster sampling for our sampling procedures, and we will focus on large urban areas. It will help us focus our research question on advanced formal training or real-time instructions during the cardiac arrest. As for the data collection, we would continue performing the study until we reach the sample size needed. We will perform one-on-one interviews with those bystanders who witnessed a cardiac arrest and utilized CPR and/or AED in the past 12 months. As for quantitative data, we will gather factual information regarding the incident as well as the bystander. Questions will include, but not limited to, demographic information, prior training, physical or mental limitations performing CPR. Qualitative data, we would prefer using semi-structured interviews with open-ended questions. The purpose of utilizing qualitative data is to help implement a health promotion program, which will seek to improve the public's confidence in potentially saving another human being's life. Using those qualitative questions, we can better understand the barriers to performing CPR and/or AED. Questions include, but are not limited to, thoughts about performing CPR on a stranger via those who performed CPR on a family member or a close friend, discussions of what would have prevented them from CPR and/or AED use, and knowledge on the need for AED use or CPR. As far as ethical considerations, we don't foresee any risk to the participants themselves. We will pull the data from cardiac arrest registries in regards to the survival rates. We are not interfering in any way in the cardiac arrest itself or the process after the cardiac arrest. The only potential risk could be difficulty for some people to talk about their experiences, especially if the outcomes were not favorable or they had performed CPR on a close friend or family member. Now, as for anonymity, we will use numbers to identify the participants instead of their names. We can randomize them with numbers 1 through 36 based on our sample size. We will use secure data storage sites and be sure to shred any paper documents after entering the information into our database. We will, of course, need informed consent, both verbal and written, for all participants in the study. Our research assistant, who would be conducting the interview, will review this document with all participants prior to their signature and completion of the interview. Participants will have the opportunity to review the document and ask any pertinent questions they have in regards to their participation prior to declining or agreeing to be in the study. As for incentives, we think a gift card would be a good choice because it is affordable and easily distributable. For those who do not wish to receive a gift card and do not care to be anonymous, we can give them an honoring plaque or simply state their name as a participant in our study on a website or wherever they would find information about our study if they wish to do so. Qualifications for our research assistant would include clear communication skills, ability to record and possibly transcribe the interviews. Basic computer skills, including familiarity with Word and Excel, would be needed. Since we will require a literature review, some level of familiarity with PubMed, Google Scholar, Cochrane, and others would be important. In addition to that, either having a basic life support certificate or at least some familiarity with the process would be needed. The following are references for the study. Thank you very much for listening to our presentation today.